Welcome to OAC Health Talks. I'm Joe Naglowski, President and CEO of the Obesity Action Coalition, and we are excited for you to join us for this educational series that dives deeper into specific health topics that we know are important to you and the OAC community. Health Talks are designed to empower you while providing straightforward, practical answers and insight from trusted experts. So let's dive into today's topic.
Dr. Narang and I are so excited to be here to share this wonderful topic with all of you. The title of our talk is actually Navigating Obesity Management During Menopause, Practical Strategies for Lasting Health. And we hope that by the end of this talk, you'll understand how menopause influences obesity. We want to help you identify practical strategies for weight management and improving body composition, and really empower you all with the tools to support health during menopause. So why is obesity treatment important during menopause? Well, up to 70% of women experience weight gain while transitioning into menopause. And up to 50% of a woman's life is actually spent in the postmenopausal years. And we know that sadly, cardiovascular disease is the number one cause of death for women, in which obesity is a risk factor. So what is menopause? Menopause is often talked about in this kind of esoteric way. It's like, I'm in menopause, but in reality, menopause actually occurs in a transition. So we know that individuals may actually start transitioning into menopause anywhere from 2 to even up to 10 years plus before they actually have their final menstrual period. When an individual has their final menstrual period, and they haven't had one for 12 months, that's actually the point which they are actually in menopause. And then beyond that is what we call our postmenopausal years. And so we know that the time that individuals are transitioning into menopause, or often what's called perimenopause, that's a very tumultuous time in a woman's body. There are significant hormonal changes and significant metabolic health changes that can really increase a woman's risk of developing a number of medical conditions, which we'll get into. So talking a little bit more about the common challenges that arise during that menopausal transition. So individuals can experience vasomotor symptoms, or what we commonly call hot flashes, which we actually know that individuals that experience hot flashes are at higher risk of developing heart disease down the line. People can experience urogenital symptoms like vaginal dryness, painful sex. There can be an increased risk of anxiety and depression. And this is all happening because of these hormonal shifts. We also know that there is changes in sleep patterns that can happen. We know that sleep is a big part of weight management that we often don't think about. And I'll talk a little bit more about that later. And there are actual changes in the body where we see individuals see weight gain, especially around the center of their abdomen. They have a decrease in muscle mass over time and bone mineral density. And this can all really have detrimental health consequences. So what causes weight gain during menopause? So we know, like most cases, when individuals experience obesity, there's just not one cause, right? We know that it's not just simply due to our diet or lack of exercise. There's a number of different factors that are going on. We know that there's hormonal shifts combined with aging and lifestyle changes that can lead to weight gain in menopause, which can lead to also other changes like sleep disturbances. We talked about mood changes and even changes in the tissue or fat tissue itself or adipose tissue itself, which can lead to metabolic diseases. So again, looking at this over the course of a transition, we know that as individuals transition into menopause, like I said earlier, there can be a redistribution of body fat or weight gain, especially in the midsection. And I'll talk a little bit more why that is particularly problematic. Individuals may actually have a higher risk of developing diabetes. They can experience worsening insulin resistance, elevated cholesterol, blood pressure, and these lead to all these detrimental changes that not only increases their risk of developing heart disease, but other conditions down the line. And as you can see, menopause really is defined by the state of a low estrogen and increased FSH levels, which are some of our hormones. These are hormonal changes that are happening in the body that are contributing to this increased risk. So thinking a little bit more about that adiposity or body fat that individuals deposit in the midsection when they are transitioning into menopause. So we know that, it's not so much about just focusing on weight or BMI. We know that elevated body fat percentages, and more specifically, where we store body fat, can really increase our risk of developing metabolic conditions and other complications. So I do want to draw attention to the fact that as individuals transition into menopause, they do gain more visceral fat, or that's fat that's closest to our internal organs. As you can see here, it's surrounding our internal organs. And we are particularly concerned about that type of fat because it's more inflammatory. It actually is communicating back and forth with our internal organs, and it can lead to disease development. And that is different from subcutaneous fat, which is what we store more on superficial parts of our body, especially our hips, thighs, and buttocks, arms, and other places that are not deep like our internal around our internal organs. So thinking a little bit more about the management of obesity and menopause, I like this picture because it does remind us that, treating obesity, especially in menopause, isn't about just picking lifestyle or medical management, and that we could really use both to help improve health outcomes and quality of life for individuals that are in this transition and beyond. I love to think about menopause in the course of a woman's life. So we really have to think about taking a life course approach when we're talking about not only trying to prevent obesity, but treat obesity effectively, and also the other metabolic conditions that occur alongside with obesity oftentimes. So it's not just viewing somebody's life in one stage, but we know that, women transition through different parts of their lives every 5 to 10 years. And so when we talk about prevention of not only diseases and prevention of complications of diseases once they set in, we really have to take all of these factors into account and start as early as possible. So oftentimes I am counseling patients well before they even transition into menopause about these risk factors, about these considerations, so that they are not blindsided, frankly, because a lot of people don't even, they don't really know what to expect when they're transitioning into menopause, so that they understand what they can do now to try to prevent complications down the line. And again, thinking about the number one killer in women, unfortunately, being heart disease, especially as that risk increases as individuals transition into menopause, we have to think about all of these risk factors. So, there's traditional, what we call risk factors, typically things that we think about like smoking and diabetes and high blood pressure and high cholesterol, obesity that contributes to heart disease risk. But we also have to recognize that there are specific risk factors to women. For example, premature menopause, when individuals go through menopause before the age of 40, that's considered, quite early to experience menopause. And we know those individuals are at particularly high risk of developing heart disease and complications down the line. Individuals have PCOS, other inflammatory or autoimmune conditions. All of these things have to be taken into the context of the evaluation when we're talking about helping individuals live their happiest, healthiest, and longest life. So here are some key clinical questions that I often discuss with my patients, especially as they're approaching menopause or transitioning into menopause, or even beyond menopause in the postmenopausal years. We definitely focus on their reproductive and hormonal health. I ask them, have they had any issues in pregnancy, like gestational diabetes, or was it harder for them to lose weight postpartum if they were struggling with obesity? Did they notice any weight changes around menopause or perimenopause or menstrual cycle irregularities? And had they ever been diagnosed with PCOS? We talk a little bit more about how well do you sleep? Do you wake up feeling rested? One of the most common concerns that individuals have when they are transitioning into menopause are sleep disturbances. There's true disturbances there, whether it be from lifestyle factors or whether it be from hot flashes or vasomotor symptoms. Sleep is impaired, and that can really affect somebody's quality of life. What type of physical activity do they like to do? What can they do on a regular basis? And if they can't, what are their barriers? and what's really worked well for them in the past when they've thought about dietary changes to either help obesity or other medical conditions, what hasn't worked. I often like to go through that history because sometimes I hear from patients that what worked really well for them in the past isn't working currently in the present, and we really try to explore those barriers and challenges to help them come up with a plan that works for them moving forward. Talking a little bit more about eating behaviors and mental health, incredibly important. We want to really screen for eating disorders or even disordered eating behaviors. Have they ever had binge eating syndrome? Do they find that stress and emotions affect eating habits? A lot of our patients do struggle with that. And then thinking about the psychosocial and structural factors, does stress and caregiving responsibilities really make it hard for them to focus on their health? Have they experienced weight stigma because of this? And do they have access to healthy food and a safe space for physical activity? I think these questions are incredibly important. I think Dr. Narang and I would agree that oftentimes we have patients that are coming into our clinics well after, their children have left the house and now they want to focus on their health. And it's really concerning to us because we wish we could have caught them earlier so that we could have helped them, while they were going through a lot of those challenges. So it is important for us to understand that. So goals of obesity treatment. I often tell patients that the goal of obesity treatment is not to normalize the BMI. Oftentimes, a lot of patients come in and, they ask, how much weight should I lose, which we'll go over. But oftentimes they're like, well, I need to lose X amount of pounds to get to a normal BMI. Because at the end of the day, the goal of obesity treatment is to help patients live their happiest, healthiest, longest life, improving their quality of life and their health outcomes. And more importantly, also improving their body composition. So thinking a little bit about our treatment options, we have treatment options all the way from lifestyle modifications, which in reality will mostly yield modest effects for most people. There might be some people that are more responsive to lifestyle modifications as far as weight loss, but we know that combining the lifestyle modifications with medical management often yields a greater response to treatment and greater improvements in health. One of the most common questions is, how much weight do I need to lose? And I often tell patients, if we can work on improving your body composition and really working on at least a 10 to 15% total body weight loss, that can really improve a number of different health outcomes. If an individual desires to lose more, we definitely discuss that as individual on an individual basis and define their goals. And we do have therapies that help patients actually, achieve a 20 to 25% total body weight loss now, or even more. We're talking about bariatric surgery, as you can see. I will say that even though I said earlier that the goal of treatment is not to normalize the BMI, that a lot of the criteria that insurance companies use to determine whether or not they cover medications, for example, for obesity treatment are BMI based. So unfortunately, we can't get around that. But clinically, there are definitely a number of different outcomes that we look at when we talk about response to treatment. So again, moving beyond body mass index, going back to what I said earlier, we really want to look at not just, how much body fat somebody has, the percentage, but where are they storing it and how is that impairing their health? So there really has been a paradigm shift to try to move away from, targeting a BMI or just kind of focusing on the BMI and looking at body composition, improvements in, functional status, quality of life, and health outcomes. So there's a number of different body composition modalities available, but these are the most commonly that are used in our clinical kind of settings or practices, I should say. So DEXA is the gold standard, a DEXA scan. You may be familiar with it when it's been discussed in the context of screening for osteopenia or osteoporosis, but you can actually also obtain body composition from it. Not all, health institutions have that as a capability, but there's actually some companies out there that are offering it. And sometimes I have patients go and get it through that company, and then we discuss it and interpret it within the context of our clinical setting. We also have machines that are in the office. These are bioelectrical impedance machines. I use these on a regular basis. It really helps our patients understand, again, that, it's not just about focusing on the weight, or it's not just about focusing on the BMI. Like, look at these changes that are happening because you're implementing all of this treatment. And it's really motivating for patients to have those discussions, especially when we're talking about, hey, if we can incorporate some more exercise, we can hopefully see some improvements here. And I'm going to pass off our presentation now to my colleague, Dr. Disha Narang, who will take us home.
Thank you. I am going to start off talking about the general principles of nutrition for menopause. There's no one-size-fits-all approach to nutrition. A calorie deficit is essential for weight loss, but achieving one is really challenging in today's food environment due to powerful neurohormonal mechanisms that resist it. So what that means is that old adage of eat less, move more, doesn't always work for a lot of people, and it becomes especially challenging for women in menopause. So while a caloric deficit does drive weight loss, what we still eat does play a crucial role in long-term cardiometabolic health. So we want to look at whole, clean foods like lean proteins, fruits and veggies, whole grains, legumes, beans, lentils, and that makes it easier to sustain a calorie deficit. So again, that translates to quality over quantity. Cooking more meals at home obviously is much more beneficial than eating out and getting takeout. For optimal nutrition, we want to aim for about 1.2 grams of kilogram of lean protein based on adjusted or ideal body weight. So self-monitoring, of course, does help to increase awareness of food choices and portion sizes, and that makes it easier to make informed decisions. So, there's no easy way around this. A lot of it does include planning, really kind of preparing for what you're going to eat day to day so that you feel like you have more control over your nutrition. So for patients who are on GLP-1 medications, we do need to make sure that we're making, appropriate and careful nutrition adjustments, and that can help to improve medication tolerance. So for example, you don't feel so good when you eat a greasy, fatty meal when you're on a GLP-1 medication. Patients often feel better when they're eating smaller, more frequent meals and lighter foods at that. Which dietary approach works best during menopause? We do recommend eating more fiber-filled foods such as fruits, veggies, legumes, and whole grains. We do also want to prioritize lean protein, and that can come from animal sources or plant-based resources. Healthy fats include olive oil, avocado, and nuts. We do want to also limit added sugars, refined carbs, and alcohol. The recommendations for exercise are about 150 minutes of moderate intensity aerobic activity every week, and then twice a week of muscle strengthening activities, or on 2 more days a week that work all major muscle groups. So we do really recommend strength training, especially in perimenopause and menopause. So resistance training, of course, is recommended for people of all ages and abilities who regularly participate in resistant exercise, and that reduces the risk of numerous diseases, improves quality of life, and reduces mortality. Of note, we start losing muscle at age 30. So it's really, really important, especially as we are having these hormonal shifts with a decrease in estradiol, that we're really emphasizing muscle training. And so, for example, we want to make sure that we are looking at free weights, machines, even resistance bands. We want to make sure that we are performing 8 to 10 multi-joint exercises that do stress the major muscle groups. And we want to do repetitions as well. Sometimes it may be important to work with a trainer to make sure that you are doing safe and effective exercises so that you're not injuring yourself. However, even something simple as having resistance bands can make a big difference over time. So things to know on logistical considerations about medications to treat obesity. There are no average patients. Mean weight loss reported in clinical trials is only a guide. So some patients might lose less weight than we see in clinical trials. Some patients might end up having more weight loss. So there is significant inter-individual variation in response to medications to treat obesity. So some patients, again, might respond really well. Others might be hypo responders and might not respond at all. We can't predict response in advance, but early weight loss, of course, is a predictor of continued response to treatment. The titration of these medications has to be individualized. So, for example, if someone is losing weight at a lower dose, I always say there's no race to the top dose, right? So if you're losing weight at a lower dose, sometimes you can increase your time on it and really maximize its benefit. People with diabetes usually lose less weight. And we've seen this across all the GLP-1 trials as well, that patients who do have diabetes have a little bit less weight loss than those who do not have diabetes. The cost and insurance coverage is a huge rate limiting step. Out of pocket, these tend to be about $500 a month, and then only certain people's insurance covers these versus others don't. So this is a major rate limiting step these days. However, we are optimistic for the future. Let's talk about the mean percent change in body weight. Over time, the advancement in medical weight management has really increased. So in the medications that we are using today, the amount of weight loss is much greater. These days, we're more often using GLP-1 agonists, which are liraglutide and semaglutide, and tirzepatide is a GIP GLP-1 agonist. So these graphs are really useful to help answer that question, well, how long do I need to be on medication? Looking at this a little bit more closely, when in the tirzepatide trials, and if you look back similarly in the semaglutide trials, patients were taken to week 20 on treatment, and then at week 20, participants were switched to placebo or continued treatment. You can see that similarly in the tirzepatide trials. In this trial, patients were taken to 36 weeks of treatment, and then half the group was taken off of medication onto placebo, and half the group was stayed on medication, which is tirzepatide. What we can see is the groups that were on placebo actually regained the weight off of the medication, whereas those who were on medication maintained weight loss. So what this emphasizes in both tirzepatide and semaglutide is that these are chronic therapies and they're recommended for long-term use. This is not recommended for a few months use to get weight off and then, expect that weight will stay off. That typically does not happen. People do regain weight. So it's really important to understand that these are long-term medications, and it's really important to make sure that we're understanding weight or obesity as a chronic disease that is deserving of long-term therapy, just like high blood pressure, high cholesterol, diabetes. So we treat obesity in the same manner. So in the pipeline, it's actually a very exciting time to be a weight management specialist. We're only at the start, I believe. Right now, we are seeing upwards of up to 22 to 23% excess body weight loss with tirzepatide, and we have even more agents in the pipeline. So what that means is that we potentially will have more choices. We have increased technology, which is very exciting, but then that also might translate to a lower price. We don't know that yet, but we're already seeing the prices drop somewhat, which is hopefully going to make these more affordable to the general public. Of note, by 2030, 50% of our population is expected to have a BMI above 30 or more. And so it's really, really important to make sure that we are starting to address obesity as a disease. So menopause hormone therapy. It comes in patches and it comes in the form of pills, but hormone therapy is FDA approved for these reasons. If someone has hot flashes and night sweats that are moderate to severe, it helps to prevent bone loss like osteoporosis after menopause. So it helps to preserve bone mass. It helps to reverse low estrogen levels, and that can lead to or happen from hypogonadism. It can happen from patients who've had their ovaries removed, so bilateral oophorectomy, or for patients who've had primary ovarian insufficiency, where they've had early menopause before the age of 40. It also helps vaginal symptoms like dryness, pain, or irritation. If your main symptoms are vaginal or urinary, so for folks who do not have hot flashes or other systemic or body-wide symptoms, doctors may just recommend low-dose vaginal estrogen treatments instead of pills or patches that reaches all of your body. So this will be localized therapy. Menopause hormone therapy, low-risk hormone therapy, is for patients who've had recent menopause, they've had normal weight, normal blood pressure, they're physically active, and their 10-year ASCVD risk is less than 5%. ESCVD risk is basically your cardiovascular risk, and they have a low risk of breast cancer. Intermediate risk includes those who have diabetes, have a smoking history, high blood pressure, obesity, they have a sedentary lifestyle or limited mobility, autoimmune diseases, such as, for example, rheumatoid arthritis, hyperlipidemia, which is high cholesterol, metabolic syndrome. Their cardiovascular risk is over 5 to 10%, or someone has a high risk for breast cancer. Patients who are high risk for hormone therapy are those who have congenital heart disease, those who have ongoing coronary artery disease or peripheral arterial disease, that they have a history of a blood clot or a pulmonary embolism, they have a history of a stroke or a heart attack, or they themselves have a personal history of breast cancer, and their cardiovascular risk is above 10% over 10 years. So menopause hormone therapy is not approved for weight loss. It should not be specifically used to manage weight or body composition. It is used for management of all the other symptoms of menopause that we talked about. When we add menopause hormone therapy to weight management medications, that's where we tend to see success in weight loss. So this is a study for weight loss response to semaglutide in postmenopausal women with and without hormone therapy use. What we saw was that the addition of hormone therapy actually allowed for increased weight loss. So again, it's not either or, it's when we marry these therapies is where we see increased benefit. This is a newer study that just came out looking at body weight reduction in women treated with tirzepatide by reproductive stage. So this looked at premenopause, perimenopause, and postmenopause. And at each age group, we saw weight loss. And that, was independent of other cardiovascular issues or any of that. And so what that tells us is that in that postmenopausal group or those who are in perimenopause, really addressing weight management with weight management medications such as something like tirzepatide or semaglutide is highly beneficial. So that concludes our slides. Again, I'm Dr. Disha Narang. Please feel free to follow me on social media, and also Dr. Nisha Patel, also on social media. Feel free to ask us any questions on there and to follow us, and we are happy to engage further.
If you found today's Health Talk valuable, we invite you to help us continue providing trusted, science-based education about obesity and health. As we celebrate 20 years of education, advocacy, and support, your generosity helps ensure that we can reach even more people. Visit obesityaction.org/donate to contribute today. Your generosity fuels our mission. Thank you for making a difference.